Okay, I think David I can no longer see David there. Sarah, do you want to give it a start? What's your take on the presentation?
Yeah, sure. Thank you, Femi. I thought the presentation was great, and I really enjoyed hearing the updates and key takeaways from the antenatal corticosteroids trials that have been underway. I think one question that I would be interested in is sort of what happens next? Like, are we ready to move these takeaways to implementation, or do you think there needs to be more research, you know, in kind of less formal research settings done? Kind of what is your take on the next steps?
While we wait for the rest of my colleagues to join, I can respond to that. I think what we're clear about now is that antenatal steroids worked in for babies less than 34 weeks in low and middle income countries or low resource countries. We are still not sure whether there is mortality or even morbidity benefits for late preterms. That is about 34 weeks up to 36 weeks and 0 days, or 36 weeks and 5 days. So we need to take care of the efficacy question around that. And WHO is already in the process of coordinating a similar trial like Action 1 trial in a similar setting, exactly the same hospital, but with additional hospitals now to answer that question. So we'll be looking at late preterm steroids, but not just dexamethasone this time around, but betamethasone as well, with a different, with a lower dose of steroid compared to placebo. So that will take care of that part of the question. However, with what we know already, we can already start to take this aspect to scale. But as you know, it is not, you know, there's always that gap between what you know and what people can practice. You know, even when you update the recommendation and you publicize it, there's a lot that we learned from Action 1 that people really we need to sort of test out in real world setting to see how that will work. So one thing that we're doing right now is to generate evidence around the implementation aspect. As you know, the ACT trial was more or less formulated as an implementation research, population level, multifaceted research. However, you know, just to scale up steroid and then see the impact of the steroid, but unfortunately the result was negative. So now we're trying to do something similar, but you know, not just too focused on the research part of it, but trying to really use the country-led kind of model. And WHO has received funding from the foundation, from the Gates Foundation, to develop what we call an implementation model for delivering antenatal steroid in 4 countries, and then scale up this model, you know, over a number of districts in the 4 countries to see whether that scale up will make a difference in terms of neonatal mortality, safe use of steroid, and things like that. So coverage outcomes, you know, health outcomes, and the likes. So there's no doubt, you know, the next thing to start thinking about is how countries will take this to scale. So that's an important question. So I see Leah, you want to ask any question or
yes,
clarifications?
Sure. Thank you so much. And again, thank you for that excellent presentation on this topic that is so interesting and has so much history. My question is, how do we ensure proper gestational age dating in the settings that we're working with the limitations that we have, not only with provider skills and knowledge, but also with equipment availability and how to scale that? Thank you.
Very, very good question. It's I think one of the most difficult areas in the management of preterm is actually gestational age dating. If we get that right, I think we solve half of the problems. And as Shiva said in his presentation, what made a difference in this trial was that we made that special effort to do that. In fact, all facilities were provided with at least one ultrasound machine, new ultrasound machines. With the trainee, ISWAG was able to support us with trainers from high-income setting that who travel to this site. But moving forward, one thing that we also learned from the trial was that even when you provided the machine, women don't come soon enough to get ultrasound done. So people were still coming very late. They're coming at different times of the night, and it's going to be very hard to have just one single machine, one ultrasonographer who can take care of all women coming at various times in the hospital. So the use of handheld devices would become more and more popular in this area. And there are several innovations around this right now. One thing we're not so sure of yet is how accurate they are in determining gestational age. And I know HighSwag is doing some comparative studies looking at some handheld devices that are in the market. One thing that we're also doing as part of the project I mentioned before regarding this implementation or scale up of ACS is trying to scope the field to know what is out there in terms of handheld devices or portable devices that could be in the labor ward right at the point of care. And they should be those that will require minimal training, not just training of obstetric physicians or obstetricians, but also midwives, who might be the first to come in contact with these women. So I think we'll have to think of multiple approaches to be able to achieve this. There's that realization that accurate gestational age dating is critical to the result that you get, because selection of what we call the right woman, for the right treatment at the right time starts with ultrasound dating. But one thing that we also found in action trial that we found quite interesting is that it really didn't seem to matter much whether the gestational age, whether the ultrasound dating was super accurate, like you expect for those that came in early first trimester ultrasound. When you compare the findings, even with those that had late trimester ultrasound, the benefit was still there. So it means having any ultrasound is better than having no ultrasound. So if you have a handheld device, will definitely be better than the woman not having any ultrasound at all, even if she's coming very late during very late in pregnancy. Does that answer your question?
Yes, thank you very much. Thank you very much for that answer.
Okay. Let's go to someone else. Sureka? Sureka, are you there? I'm seeing a name that looks like Tish. Tish, is that you? Okay.
Hello. Hello.
Hello, Sureka. Please, you have the floor.
Yeah. Hello.
Hello, please go on. Sureka, do you have any question on the last session on antenatal steroid?
I still use the chat.
Yeah, if anybody wants to use the chat, please go ahead and use the chat. I don't know the person with Oachola at yahoo.com. Do you want to comment, or do you have any question or clarifications?
Hello, I'm sorry, I'm late. I joined very late, so I don't have a question. Thank you very much.
Okay. David, you're back. So do you have any question or clarifications? David Trishua.
Hello.
Hello, David. Please go on.
Yes, good
Your
afternoon.
views of...
Yeah, good afternoon. Oh, yes. Yeah. Sorry, my network is not very well, but I'm really happy to join this group. And maybe it's also more like a comment which is related to dating, because this is the most challenge we face also in Rwanda. And as you mentioned very well about doing ultrasound, especially in pregnancy, this is a big challenge because most of women tend to come a little bit late. And even those who come for consultation go just at the level of the primary health care. And most of the time of the primary health care, where we see health providers who are just at the level of midwives or nurses. So maybe I was wondering what this group or what you think of maybe task shifting ultrasound to midwifery, to midwives and nurses who can just be who can be able to at least perform simple measurement, dating, and a few things to inform women exactly maybe about dating. Because one of the reasons why women tend not to come early in the first trimester also is maybe what they learn when they go at the level of the primary health care. They feel like maybe they're not going to learn a lot, but when the ultrasound is part of what they're going to get, it can also track them much more maybe in the future. So maybe what is the thought on that about task shifting? Because otherwise it's still really a challenge.
Okay, I'll say a little bit and then pass it over to my colleague, Dr. Aide. I think gradually we're sort of moving to a stage where task shifting of or at least basic ultrasonography becomes possible. And I'm saying that because there are lots of innovations around ultrasound, portable ultrasound devices these days, where you really don't require specialist level skills to be able to use the machines to conduct gestational age assessment, for instance. So I think that there is a lot of positive things happening in that direction. But right now, there aren't too many midwifery programs that are using this kind of methodology to improve gestational age dating. I agree with you that if there's ultrasound, generally women like to check their pregnancy, see that their babies are doing well, and that might be a way to attract people to register early for antenatal care. So I think we'll have to continue to look at that space. and with improvement in the ultrasound technologies, I think that will probably become the mainstream approach to decisional age dating, especially at the lower level and peripheral hospitals. Dr. Aida, do you have any additional point to add to David's question or comment?
Thank you, Dr. Femi. Maybe I will just add a little. The ultrasound technology is actually the way to go. Apart from that, the society, let me give an example of Nigeria. The radiologists in Nigeria have identified this gap, and they've taken a step to make sure that this gap is resolved by developing short courses where doctors and midwives can be trained over a few weeks, basically to support obstetric ultrasonography in the country. And this course has been established in, at least for now, 2 centers, 2 regional centers in the country. So this is another way in which they can have obstetric ultrasound being promoted, so that medical officers and midwives can have basic skills for doing gestational age assessment. So that would be another thing we can do. But the best is to have portable equipment handy, relatively cheaper than what we have now, and then can be accessible for as many women as possible. Then we cannot also overemphasize the role of continuous health promotion, health education, even for our mothers. So we will continue to move in this direction, and then hopefully things will improve.
Thank you, Dr. Aide. I see Leah has something in the chat box. Leah, do you want to speak to that?
No, I was just commenting on the gentleman from Rwanda's statement about bringing ultrasound to midwives, and that was I think that's an excellent approach, especially, and as well as a specialized neonatal providers looking at specialized neonatal nurses or neonatal midwives as well. And I think I'm happy to hear about the course in Nigeria, so thank you for sharing that.
Thanks, Leah. Lisa, welcome to this networking room. Lisa, I don't know if you participated in the antenatal steroid session and whether you have any questions or clarifications or suggestions. So I'm calling on you, Lisa. Yeah.
Thank you, Femi. I was able to attend part of it. As part of the Secretariat, I have had to jump around a bit, but I have seen the entire presentation. I would like to add, in response to the recent discussion around ultrasound and handheld ultrasound, point of care ultrasound, especially for midwives, that the ARC network, funded by Bill and Melinda Gates Foundation, will be examining the acceptability and feasibility of handheld ultrasound use by midwives in Malawi. We're going to be focusing in Blantyre and doing a phased introduction where we're going to be using community input, provider input, women's input to understand how we can integrate better gestational age estimation through ultrasound into the health center setting. Thanks.
Thanks very much, Lisa. Tashri Shah, are you there?
Hi, Femi, it's Tish.
I was wondering.
Unfortunately, I missed the talk, but I've seen the presentation before and was very impressed with the data. So I was wondering what the questions and Q&A would be afterwards. So I thought I'd join. Yeah, I mean, it's really interesting, the discussion of point of care ultrasound, but I was also thinking, I've had experience a little bit with that, trying to implement that, and how you know, how virtual training can help with things. So you know, you have the scan, and you can, if you have the capacity to have telemedicine, it can be really helpful. And also using the ultrasound for other things. I mean, there's a lot of useful uses for ultrasound scanning in pregnancy, and you know, maybe for other uses in the health system. So yeah, investing in POCUS, or this point of care ultrasound, seems to be useful. Yeah, but then there's all the health system constraints of getting the lady at the right moment to take the steroids and everything, and it's, yeah, the tool has to be accompanied by a massive behavioral change, and the hope that something can change. And I've just seen a 27-weeker survive really well in South Sudan in appalling conditions after receiving steroids. So I'm all for it. Thanks for calling on me, Femi.
Sorry for putting you on the spot, and that's what I've been doing in this
excited
session.
by it, so it's good.
Yeah, I totally agree with you that, you know, the point of care ultrasound devices will be the way to go. I don't think it will be possible to have all women go through the big machines, you know, even once during the pregnancy. So I think the study that Lisa mentioned will really provide a lot of information around, you know, how acceptable and how feasible the use of handheld ultrasound is, especially at lower level facilities. And as part of a Gates-funded project that WHO is coordinating around antenatal corticosteroid scale-up as well, we plan to conduct a kind of scoping review to look at existing devices, their diagnostic accuracy, you know, whether they're acceptable, feasible, their costs, but this will be done through a systematic review, or scoping systematic review, to be able to provide countries that we're going to do this initial study, provide them with some you know, options of what is out there that will be cheap for them, that will be acceptable within the setting, that could be sustainable as well, and then we'll see where that whether that can facilitate or improve gestational age dating in general. So one of the other panelists just joined, Dr. Zaida Qureshi. I don't know if anybody has any specific question for her, but it's been an interesting time. It's been nice meeting all of you. But maybe before I close, maybe we should have started with a quick introduction. I was thinking we're going to have hundreds of people, but it's fine. So if we could just know it, at least use this opportunity to meet one another properly. So my name is Femi Oladapo. I work in the Department of Sexual and Reproductive Health and Research at WHO. I'm the head of Maternal and Perinatal Health Unit in that department. So I'm going to call on the people that have spoken before, so at least we get to know each other. I'll start with you, Leah.
Hi everyone. My name is Leah Greenspan. I am a senior newborn advisor for USAID here at headquarters in DC, and I am also a neonatologist.
Perfect.
Thank you.
Tish, you want to introduce yourself?
Yeah, I'm a pediatrician specializing in infectious diseases and immunology, and I'm currently working with WHO for the STAGE Secretariat, so the Strategic and Technical Advisory Group of Experts on Maternal, Newborn, Child, Adolescent Health and Nutrition.
Perfect. David?
Yeah, thank you. I'm Dr. David Hirushpa. I'm an obstetrician gynecologist at University Teaching Hospital of Kigali. And I'm also a member of the steering committee of Align MNH. And I'm happy to see Dr. Zad Qureshi, who has been my mentor at University of Nairobi during my training 7 years ago. Thank you.
Okay. The objective of this session has just been realized. This is what you do when you go for conferences. You meet your old colleagues and friends, and that's part of the purpose of this. So over to you, Sarah.
Yes, thanks, Femi. I'm Sarah Webb. I'm the program manager for Align MNH. So I'm based at the Secretariat and support the Align MNH initiative across our different work streams and then working closely with our steering committee.
Thanks, Sarah. Lisa?
Thanks, Femi. Hi, everyone. Lisa Noguchi. I'm a certified nurse midwife and infectious disease epidemiologist. Currently director of maternal newborn health at Chicago and affiliated with Johns Hopkins School of Public Health Department of Epidemiology. Thanks.
Thank you, Lisa. Dr. Aide?
Aide Adejumokeju. I'm a neonatologist with the University College Hospital Ibadan and a lecturer in Department of Pediatrics, College of Medicine, University of Ibadan. I was the principal investigator for Action 1 for Ibadan site, Nigeria. Thank you.
Thank you, Dr. Aide. Zaida?
It's nice to be back after opening my fast with some nourishment and a cup of tea. Thank you. It's really nice meeting all of you. I am Zahida Qureshi, an associate professor at the Department of Obstetrics and Gynecology of the University of Nairobi, Kenya. And I was the principal investigator of the Action 1 trial. And in Kenya, we had 4 facilities that participated in this trial. And it was a very, very interesting activity. And we're really glad that we were given the opportunity. And yes, as David said, David, when he was doing his master's, spent 1 year with us at the University of Nairobi doing his elective. And I was the chair of the department at that time. So it's really nice. We did meet at another conference, the JPIGO, I think, Community of Practice PPH meeting in Geneva, in Senegal. So yes, it's nice to interact with you once again, David. So yes, that is who I am. It's nice to have had fulfilled that networking finally.
Okay, thanks everyone. It's been very nice meeting all of you. I hope you taking something away from the discussions and the sessions and the interactions, and hope to maybe see you tomorrow at the conference or some other time when our paths cross. So with that, keep safe and stay healthy. Bye from me.
Thanks, Femi. Bye, everyone.
Bye. Bye, everyone.
Bye, thank you.
Thank you. Bye. Bye.
Bye, thank you, Femi.